Hello and welcome. My name is Ali Sederat. I'm a gastroenterologist at UCLA, and I'm going to talk to you about colon cancer screening. Colon cancer is common. It's the third leading cause of cancer death for both men and women in the United States. In 2020, there were 53,000 deaths related to colon cancer, and overall, the lifetime risk is 4%. Importantly, colon cancer is preventable. Screening identifies early cancers or precancerous lesions which can be removed to prevent advanced cancer and morbidity and mortality from cancer. Because of nationwide screening programs, the incidence in the screened population, namely those over age of 50, has decreased. However, screening is still underutilized in the United States. So what are we talking about? These are two lesions, very different lesions in the colon. On the right picture is an advanced colon cancer that's causing a bowel obstruction that was diagnosed on a CT scan and then subsequent this colonoscopy. The wire is in place because we're about to place a stent for that obstruction. On the left is a very, very tiny polyp, barely perceptible bump on the wall. You may not even be able to see it right in the middle of the screen there. That's a polyp, and all cancers grow from tiny polyps. Not all polyps become cancer, but the goal of screening is to identify and remove polyps that have the potential to transform over years into a cancer. So these are other examples of polyps. This is a larger one that could still be endoscopically potentially removed. Here's a little flat, subtle one. Here's a kind of a carpet-like polyp. Here's another pretty extensive polyp. Here's one that's called pedunculated. It has kind of a stalk and a head. And so these were all identified at screening before they became advanced cancers. They can be removed and prevent colon cancer. The picture in the population, the epidemiology of colon cancer is changing. In general, it's diagnosed most frequently in the 60s to 70s years of age. However, about 10% of colon cancer patients are under the age of 50. There is a recognized increased incidence of very young patients in their 20s to 40s being diagnosed with often advanced colon cancers. Though overall this is still a small absolute difference and a small overall proportion of colon cancer, it's still pretty scary, and it's recognized and poorly understood. Importantly, younger patients may present without any obvious risk factors, such as a genetic syndrome or a strong family history. Despite this, how to address this population and offer screening in younger people is not fully established. We don't really understand this emerging entity yet. So primarily we're going to talk about what are the screening methods available. There are three basically accepted methods available and recommended. The standard is colonoscopy. You have a couple pictures there. A colonoscope is basically a camera on the tip of a long, flexible tube that can be maneuvered through the bowel with high-definition images. It has a light on the end. It has an instrument channel that we can pass biopsy forceps or other instruments to remove lesions or sample lesions. There are stool-based tests wherein the stool is collected and submitted for testing, and if a test is either positive or negative, then often a colonoscopy is recommended. And then there's the CT, or the virtual colonography or colography, which is a means of trying to visualize the colon with an X-ray. So stool tests, These are performed every year once screening is started. There's different types of tests. The FOBT, or occult blood test, has been around for many, many years. It's a chemical reaction in the stool that identifies blood products. It's either positive or negative. FIT, or the FIT test, also identifies blood. It's a little more sensitive, relies not just on a chemical reaction. And then there's DNA FIT tests, which, in addition to detecting blood, can detect genetic abnormalities or products that a cancer or a polyp may shed into the stool. So the stool is collected and submitted for testing. If the test is positive, it requires a colonoscopy to visualize the colon and detect any lesions. Virtual colonoscopy is a dedicated protocol of a CT scan, so it's a little special. It's not just a typical CT scan that's designed to evaluate the colon. It's done every 5 years. It does require a bowel preparation. There's no sedation. A catheter is placed into the rectum, and air or CO2 is insufflated to distend the colon and allow visualization. And positive findings also require a colonoscopy. And there on the upper right, and on the bottom is an image of a CT colography. The gold standard, or the definitive test, is a colonoscopy. Its advantage is that it allows direct, complete visualization of the colon and direct sampling or removal of lesions. In the United States, it's generally considered to be the preferred method where it's available. It requires a full bowel preparation. Sedation is often used, though it's not 100% necessary in a lot of patients that are otherwise healthy. The quality of a colonoscopy, though, depends on a skilled doctor and the quality of the bowel prep. And the interval for a colonoscopy in an average risk patient is every 10 years. So what does average risk mean? For most, guidelines agree that age 50 and over, everyone should be screened. The United States Preventative Service Task Force in 2020 has a draft statement to propose lowering the age for everyone at 45. There's also recommendations that African Americans who are at elevated risk for colon cancer be screened at age 45. The American Cancer Society has a strong recommendation for 50 and has a qualified recommendation for age 45. So in general, somewhere between 45 to 50 is accepted as a screening age, certainly over 50 for sure, and more likely than not in the coming years, the standard recommendation will be lowered to 45. So that's average risk. How do you know if you're at higher than average risk? Well, that's a complicated question. In the absence of an obvious known genetic syndrome in your family, your risk should be assessed with your primary care doctor roughly around age 20 to 30. So sometime in your 20s, when you're first thinking about seeing a doctor as an adult, one of the things that he or she will go over with you is assessment of your cancer and colon cancer risk. Those that have a personal history of colon cancer are obviously at elevated risk, but also a family history of colon cancer or significant polyps, particularly if there's multiple family members, multiple first-degree family members, and family members diagnosed at less than 60 years old with colon cancer. There's a number of known genetic disorders associated with colon cancer. FAP is one of them, perhaps the most famous, and this syndrome is perhaps where colon cancer can happen in the youngest of folks. There's Lynch syndrome and MAP, or MUT-YH associated polyposis. There's other more rare syndromes and some other syndromes that are less straightforward in terms of early colon cancer screening. If you have a known cancer genetic abnormality in your family, you should discuss with your doctor your screening eligibility. Patients that have a history of inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, are at elevated risk, as are patients who may have previously in life gotten radiation to the abdomen for another cancer. So what should you do? Where should you go? You've taken the first step, which is listen to this talk and started to think about screening to take your health seriously. So you should discuss that desire with your primary doctor. You should be asked to be referred to a gastroenterologist to discuss your screening eligibility and what your optimal method would be. And discuss if you think you might be at higher than average risk when you should start screening. Importantly, if you're having symptoms that may indicate a colonic disorder or a colon cancer, you should be evaluated irrespective of risk or eligibility for screening. So if you're having bleeding, otherwise unexplained iron deficiency anemia, weight loss, and an odd change of bowel habits, you should discuss that with your doctor. Thanks very much for your attention. Get screened.